Good morning, everyone, and welcome to the South East Maternity and Neonatal Spring Learning and Sharing webinar. Next slide, please, Sasha. A very warm welcome to you all, and we have a dedicated focus on perinatal equity today. Thank you for joining us today and making the time in your busy schedules to come together for shared learning, reflection, and collective action. We know that inequalities in perinatal experiences and outcomes persist, and avoidable unfair disparities that impact families' health, well-being, and trust in the care we provide. This is echoed in the latest national data, including the Embrace UK maternal mortality data brief that was published in January, which shows that maternal deaths in the UK remain 20% higher than in 2009 to 11, and that stark inequalities continue. Black women face nearly a threefold higher risk of maternal death than white women. Asian women also experience elevated risk, and women in the most deprived areas remain twice as likely to die as those living in the least deprived areas. And these figures underline why equity cannot be optional, and it must be central to everything that we do. Alongside this, the AMOS interim report published at the end of February continues to highlight the voices of thousands of families who describe not being heard, experience of care that can feel fragmented, and the impact of structural racism and discrimination on their safety and outcomes. These insights serve as powerful reminders that listening, cultural safety, and trust are not soft aspects of care, they're essential foundations of equitable and high-quality maternity services. So today's session is an opportunity for us to deepen our understanding of those inequalities, hear from colleagues who are driving improvement, and consider what more we can do across our services and systems to ensure that every woman, birthing person, parent and baby receives safe, personalised and equitable care. As you can see from our agenda, we have an excellent lineup of speakers who will take us through key dimensions of perinatal equity, from the vital role of interpreters in maternity to the importance of culturally informed and timely access for Black African women, to the challenges and opportunities linked to language discordance. And we'll also hear about the work happening locally in Sussex via video presentation to embed equity across perinatal services. So throughout the morning, you'll have opportunities to ask questions, share reflections, and connect with others tackling similar issues across the South East. So as I said before, I encourage you to use the chat and help this make a truly collaborative and practical session. So thank you once again for being here and for your ongoing commitment to improving equity in maternity and neonatal care. Let's get started. Next slide, please.
Hi, is that right for me to start, Charlotte?
Please do. So a warm welcome back to Mary Claire, who's previously presented on one of our webinars. Over to you.
Thank you very much for having me. So my name is Mary Claire. I'm a consultant midwife in public health and I'm at Surrey and Sussex NHS Trust. Next slide, please. So I wanted to talk to you today about the work we've done to improve our use of interpreters in maternity, and just also whilst doing that provide some background and the rationale just for why that is so important. Next slide, please. So when we look at the demographic of women who are giving birth in the UK, in recent years we have seen some shifts and changes. Women have always migrated, human beings have always migrated, this is nothing new, but the rates maybe have started to increase, and that's driven by things such as global warming and conflicts. So it's really important that we are scrutinising our use of interpreters to reflect these changes. So somebody who's a lot better at numbers than me has crunched some data from the Embrace reports and has calculated that women with limited English are 25 times, let's just let that sink in, 25 times more likely to die in the perinatal period. And I've put there how they've worked that out. So this is really key. When we're looking at learning from reports and cases, the lack of interpreter is implicated in perinatal mortality cases nationally. So it's not just maternal outcomes, it's the fetal and neonatal outcomes as well, which are affected. And then just thinking about my trust, so on average, and it does vary, 5.7% of women who book with us require an interpreter. That does change, that even changes seasonally. We see more women requiring an interpreter in summer because we see increased numbers of women who are making small boat crossings. Nationally and also locally at our trust, women with limited English are more likely to book later in their pregnancy. Next slide, please. So this is just kind of a little bit of information that I've collected. So I have been doing 6 monthly audits of our use of interpreters, which I'm going to go into in a bit more detail. But I think this is just interesting because it shows the spread of languages which we have at our trust. And what will also be interesting is that if you looked at the languages at your trust, you would see a different spread of languages, and also that spread of languages doesn't stay static. That will change depending on migration patterns. So yeah, it's just interesting to have a look at, and it's also really important data that we have this so that we can be responsive to the languages that women are currently speaking. Next slide, please. So just a reminder of the good practice that we should be considering as part of our services. And this is the good practice that I benchmarked my audits against. So NHS England says that we should not use Google Translate for clinical conversations. It's only accurate. Sorry, there's a lot of background noise. Sorry, 1 minute. So yeah, it should not be used in clinical conversations because it's only accurate apparently about 57% in clinical conversations, so it should be avoided. We should be recording women's language and interpreting needs in their healthcare record and passing this information when referring them to other health professionals. NICE has some pretty basic guidance. I think it's in need of updating, but it's all we have really when thinking about pregnancy and complex social factors. Embrace reports, particularly in 2024, there was a focus on the care of migrant women, and the language needs of pregnant women are included in the 3-year delivery plan. So I wanted to benchmark against these standards. Next slide, please. Just some more general principles as well, which I wanted to benchmark against, and this is from NHS England. We should avoid using family members for interpreting unless that is that woman's wish. But I always say when I'm doing training that if the woman is choosing, when a birthing person is choosing to have a friend or family member, that we've had a conversation with her on her own to ascertain that really is what she wants, and also to let her understand that we can't kind of govern and be assured of the standard of interpreting if it's a friend or family. Next slide, please. So I did my first audit back in 2024, and I used this layout which Charlotte actually designed, but it's quite good for including quite a lot of information in a straightforward way. And you can see that according to my audit, if you look in the results and findings box, according to the documentation, interpreters were being used in the minority of contacts, which it was alarming. But I did understand that probably people weren't documenting when they were using interpreters, which is a whole other issue in itself. I did find that there were multiple systems barriers to interpreters' use. So, for example, there might be issues using the phone for language line. There was issues around the phones working or going missing. And I did find that sometimes Google Translate was being used for clinical conversations. There were some examples of really good practice. Occasionally there was evidence that female interpreters were being specifically sought out, and that where possible we were using face-to-face interpreters for really complex appointments or elective procedures. But definitely the documentation around interpreters was an area identified as an area for improvement. So to address these gaps and these areas for improvement, we implemented a really robust MDT education program to share the learning from my audits. The learning was also shared at our OBS and Gynae's clinical governance meeting, and I planned to re-audit again in 6 months. I also wanted to consider how I could make it easier for those staff working clinically to access an interpreter, because there was clearly barriers. It was clearly really difficult. Next slide, please. So this is just a summary of my findings and the issues. There was also issues when you're using your phone and you're trying to dial in, issues with signal, and it was also creating this picture of adding to midwives and doctors and support workers' workload and stress. Next slide, please. So I came across this system, which is provided by Language Line. There are multiple systems, by the way, and I wanted to look and see what would make things easier. One that I wanted to explore in particular was this system where you have what's called a virtual interpreter on wheels. And if you look at the picture on my slide, you can see one of the screens there is literally on kind of a stand, and that stand has wheels. So the idea is that you can have access to an interpreter via video. So this is 24 hours. You can also access this service on static devices, so for example, a laptop or a phone. And there's also the option to access sign language as well. That's not 24 hours, but it's still there. I think it's Monday to Friday. Next slide, please. So the way it works, it's really straightforward, and I think this is one of the beauties of it. Whereas if you're using Language Line, you're having to dial, you're having to put your code in, it can be quite laborious. With this, you literally just look at, sorry, it's quite small. You look at the screen and you press the language that you want. If you don't want a video, you can just ask for a call, but it's touchscreen. There's a privacy feature, so sometimes if you're providing intimate care or the woman or birthing person chooses to not have a video, you can choose to not have a video, you just have the voice. There is something called, I think they call it a notes feature, where the interpreter kind of types what they're discussing, so that gives you a transcript where you can summarize the information and provide it to the person, particularly if it's something quite complex, and it runs off the Wi-Fi. Next slide, please. So the implementation for these virtual interpreters on wheels, obviously funding is always a question, and I know it's one of the things that is foremost, particularly in this challenging financial climate. The good news about this is that the actual iPads are provided free of charge. They provide 3 of them free of charge, and they provide the stand as well. So you don't have to pay for that. The only funding implication would be that the calls on the iPads are slightly more expensive than a standard Language Line call. So that's something to factor in, but it was felt to be a cost worth paying. So we were able to secure 3 iPads for the 3 inpatient areas, so for the intrapartum area, antenatal and postnatal. We received some training from Language Line, but being honest with you, they are so super easy to use, you barely really need training. We put out comms to staff, just explaining what these are, what the benefits were. We liaised with IT because we needed to go through the firewalls. IT is not my area of expertise, by the way, as you'll soon realise. And we were issued with a free trial. And this is something that you guys, if you were interested, would be able to have, which was really attractive. I think the free trial was for 2 weeks, but we possibly had an extension. Next slide, please. So there were challenges. As I said, there was that cost implication of the increased cost for the cause, but we got approval for our senior leadership and we were able to put a really strong case for the rationale. The setup was challenging. It took a really long time and lots of pestering to work with IT to get the firewalls negotiated, but we did get there in the end. As with any equipment in the clinical area, these are prone to damage. They get pushed around. They get used in emergencies. So we have had broken plugs, but we've been able to overcome that. Occasionally, there's been situations where a language has not been available. 3 o'clock in the morning, you're trying to do an unplanned cesarean section and we've not been able to get interpreter. Those occasions are few and far between, and when it has happened, the staff have submitted an in-phase, so I've then been able to submit a complaint to Language Line, which they can then follow up. Next slide, please. So the results of using this service, when I re-audited following the implementation of this, I could see that in the intrapartum and the antenatal day unit, the use of interpreters had doubled. The feedback from the women through the MNVP was really, really encouraging. They said they really enjoyed having the service. They liked being able to see who they were talking to on the screen. The service was user friendly. There was so little training needed. Multiple staff would come up to me, people who I didn't even know sometimes, and be like, "Oh my gosh, Mary Claire, we've really enjoyed this." I had an anaesthetists emailing me to say what a difference it was making. I think they particularly enjoyed that it could be wheeled into theatre really, really easily, which then made their discussions easier in theatre. A midwife came to me and said that it was absolutely life-changing, and the paediatric service have copied us because they enjoyed borrowing ours so much. Next slide, please. So I carry on now re-auditing, and as you can see, there's still work to be done, but we can see there's been a really considerable improvement in our use of interpreters. Next slide, please. And it can be really overwhelming when you're trying to think about, how do I book an interpreter? It's not just about language line. It's not just about virtual interpreters on wheels. Sometimes it's considering the need for a face-to-face interpreter. And I've always appreciated it can be overwhelming for staff, and I've had feedback that they can get confused. So I created this guide just to kind of make it a little bit easier for them, because it can be really confusing. Next slide, please. So just to conclude, that ensuring access to interpreters is a really key component of equitable maternity care. I think that's non-negotiable. It's part of the NHS constitution, and it's really important that women understand they have a right to an interpreter. Video interpreters have reduced stress and workload. They're really helpful if needing to transfer during labour in an emergency situation, and we find they're easy to use. However, these virtual interpreters, they're great, but they're just part of the picture. It's not just about the systems that you use. It's about the staff who use them. It's about the people it's about the women and birthing people who are the end users. And it's just part of our overall strategy to drive improvements in our use of interpreters. So the other things that have been really, really important is education around using interpreters, not so much the technical use of the screens, because it's very easy. It's about understanding the rationale behind how important it is, and also providing comms to staff as well. Next slide, please. So just to summarize, I think this is a really lovely quote. This is attributed to George Bernard Shaw and somebody else. So thinking about what Charlotte was saying in the beginning about listening to women is so basic, but we just don't always get it right. The single biggest problem in communication is the illusion it has taken place. So let's do our utmost to ensure that we have done our best. Thank you. Questions and comments would be very welcome. Thank you. Oh, and there's just a reference.
Thank you so much, Mary Claire. So much to take away from that brilliant piece of work. We've had a couple of comments in the chat about language line while people are thinking, oh, we've got somebody asking a question. Danny.
Hi there, I popped it in the chat. Thank you, Mary Claire, for that. It was really interesting to listen to, and that 25% is shocking.
Yep.
Do your MNVP have access to the translation software to collect the feedback?
So I think it's really difficult because it comes down to funding. So they have their budgets are separate. So they tend to use their own interpreting services to collect feedback, but they do use interpreters to collect the feedback, but I'm not quite sure what they use.
Okay, no worries. I'll touch base with them separately and yeah, pick some brains. Thank you.
Yeah, definitely. Thank you. Margaret?
Hi, Mary Claire. I'm Margaret, and I'm a midwife from Hampshire and Isle of Wight ICB. And, I was just thinking when you were talking about, maternity is uniquely different with complex decision making across the whole pathway. And labour is unique, isn't it? Because it's long and protracted and constant conversations. So I was really interested to hear what you were going to tell us. And it sounds really, really good. Tell me, are the interpreters real or are they AI?
That's such a good question. They're absolutely real.
Okay. And how many times in that period of time that you were looking at that, did you have access to, so for somebody in labour, for instance, it's very private, very sensitive with people from other cultures and ethnicities, and ensuring their dignity across that period. Did interpreters change across, somebody was in labour for 12 hours, say, as a minimum, that they change? Did you have access to what you needed at the right time?
So I'd say in the majority of cases, and I have been told that there've been labours where they've had the same interpreter throughout the whole experience, and it's almost like the interpreter kind of came with them as part of the team and a part of the journey. And if they needed to transfer to theatre, they just if it was plugged in, they unplugged it, and like you would with a drip stand or something, or any other, or something else, and took them with them, so they could then literally take them with them into theatre, and where needed, turn them off. Turn the camera off. Something I forgot to say, you can also request a female interpreter with this. When you press the button, you'll get someone show up on screen. If it happens to be a man, you can say to them, and I've done it myself, oh, we'd prefer a female interpreter, could we please just go out again? And they'll do it. Thank you.
And
Thank you.
could you share your details in the chat? Because I think
Yeah,
I don't
course.
go even across my area, very rarely do I have a day where people don't talk to me about translation, really. And I think it's probably cost neutral when you think of people not really understanding decisions that they might make. So well done, Mary Claire.
Thank you, Mark. And also time saving. If we're going to think about efficiency, it's time saving. If anything else, apart from safety. Caroline.
Just one more quick question, then we'll move on. Thank you.
Yeah, sorry, it's two parts to it though, so sorry, I'll try and be quick. The first part is, Mary Claire, how much scope in terms of languages, and you might have said it in the presentation, so apologies if I've missed it, but how many languages? Because what we're finding is on offer, because what we're finding, I went to our Equal Start Oxford celebration event last week, and one of the things that we did when we originally set that programme up, we had a real issue because we had a large number of women that spoke Tetum, and there's only 2 national interpreters of Tetum. And what we're now finding is there's even more niche and unique languages that are being utilised from women in that particular project. So I imagine this is not unique to that particular area of Oxford, and this is unique to a lot of other places as well. So the need for specific interpreters for different languages that are not common are required. So what's the scope in terms of kind of what's on offer on your video things? And then the second thing I just wanted to say, so this is more of a comment, is that in our ESO programme, one of the things that we have done in the last year and a half, so we've trained up maternity advocates. They are now linked to an interpretation school that train interpreters for Language Line, etc., and they are community interpreters themselves now. So we've had about 10 women that have gone through that programme that offer interpretation in the community. So there's something about how we utilise our community assets as well. That comes with challenges itself, because obviously we've had issues where women are slightly distrustful because they're not sure how much will then go back to other community members. But that's just a comment more than anything. So the question was around the scope of the languages on that VR service.
So for the service, they say that they have 240 plus spoken languages and 40 plus video languages. So sometimes you can get a language on the iPad, but you can't get it via video. But to be honest with you, it doesn't really matter as long as you're getting that language. So yeah, it's fairly broad, and I'm very jealous of your advocates. I'd love something similar, but I'm not going to take any longer because I don't want to take any time for the next speaker. Thank you so much for being engaged. Thank you.
Thank you so much, Mary Claire. So such a brilliant piece of work, and hopefully you'll be able to come back another time and present on your next project and maybe talk about advocates next time. But maybe do connect with Carrie as well to see how you can look at doing that in your area as well. So let's move on to Denise Chalice. She's the MNVP chair at Royal Berkshire Hospitals, and she's going to come and talk to us about an early booking project for Black African women. Over to you, Denise.
Thank you, Charlotte. Thank you for giving us the opportunity to speak about our work around co-production this morning. So my name's Denise. I'm the lead of our Royal Berkshire Hospital MNVP, so Maternity and Neonatal Voices Partnership. First to say, when we do co-production work, that work is a result of both listening to service user voice, it's a result of partner feedback also, and it can come from our own data that we collect off the back of the feedback that we receive, but also trust data. So this particular project that I'm going to talk to you about this morning came from data that was shared with us within the trust. This is just one. I know I'm here to talk about booking appointments for Black African women, but actually as an MNVP, we're really proud of the amount and the scope of the co-production work that we do. I have my co-lead with us this morning, Danny Miller. She asked a question a moment ago about the translation service. And Danny and I, you know, we have led on many different projects. Danny's led on, she was a part of the Royal Berkshire MNVP before I was, and has led on lots of really meaningful, impactful co-production and QI projects. And she'd be really, really happy to share any questions that you have in the chat today about other work that we're doing. And we'd love the opportunity to come back and for us to talk about more of our work. We're very passionate about co-production in Reading. So historical co-production projects have included a dedicated home birth team. Danny's led on a rewrite of many different service user communications and leaflets, elective caesarean and induction of labour leaflets just being two of them. Infant feeding charts. We have family bays at the Royal Berkshire Hospital where partners can stay with their new baby and their you know, their birthing partner for 24 hours as long as that person is in hospital. And we're really, really proud of those. And actually, it's had a huge impact on service user experience. Soundproofing of the bereavement room. We had a service user named Di who had experienced baby loss and had done one of our 15 steps and had reported on that. So she'd fed back on her experience of being in the bereavement room and hearing other women and families and their babies crying. That was then acted on by the Trust and by the MNVP and the Royal Berkshire Charity. And she was able to come back on a 15 steps and was able to see that and go in the room and experience that change. So that's the power of co-production. Current projects that Dan is leading on: antenatal education videos across Bob, a care pathway for service users that have had experienced baby loss before 16 weeks. And I've done some work very recently around access to our triage line for Black African women. So I am here today to talk to you about maternity appointments for Black African women, but we are so passionate and so proud of the co-production work that we do in partnership with our service users and partners and trust. I just wanted to kind of put that out there. So can we have the next slide, please? Oh yeah, I've done that one, sorry. Thank you. So this here is some data that was shared with me by the Trust in early 2024. So what this shows is that Black African women were significantly less likely to make their booking appointments within that 8-week window. And we know that a delay in making a booking appointment, the knock-on effect of that is a delay in accessing the safest care pathways, because they do need those, tests around potential blood disorders, thalassemia and sickle cell. And again, as I said a moment ago, it is about the delays in getting on the right care pathway. Just a bit of context here around as the MNVP was at that time. So in terms of representation for our community in Reading, across our footprint in Berkshire, we have a really, really diverse community. It's phenomenal. But as an MNVP, we weren't particularly representative, both in terms of our team, but also in terms of the feedback that we were hearing and those community and members of the community that we were hearing it from, and also our organisations that we were partnering with. As a result of that, we have prioritised and really significantly invested over the last couple of years in increasing the representation of our team. Our team is more than doubled the size. I think it's probably 3 times the size of what it was when in early 2024, actually. We've really significantly invested in partnership in terms of connecting with and building relationships and sustaining and nurturing those relationships with our community leaders and partners across our patch. And just building on our connections with community and hearing from a broader range of voices, as many voices as we can. So that was kind of a bit of context. So in terms of this project, we had an awful lot of work to do in being able to build those relationships in order for us to hear the voices of Black African women in the first place. And that took some time. Next slide, please. So there's a lot on this slide, and when I sat down to kind of update it before I sent it over to Charlotte and Sian, and the left-hand side of the slide really shows a kind of pathway in which, where did we take this conversation? So what we did right from the outset, our approach was one that is community is an asset. And I firmly, and our team firmly believe that community have the answers and the solutions if we ask the questions and we share the resource. And so what we did is we created a kind of it was a bit of a roadshow. So we took that conversation everywhere that we went. So on the left-hand side, there's lots of different events that we went to across our community. But we took it everywhere. Every conversation that we went into was an opportunity to share and ask those questions and to reach out and ask to be in spaces where we could talk about it more. And it's also remembering that when we talk about Black African women, there are 54 countries represented when we talk about Africa, and each of those have unique languages, dialects, cultural differences and lived experiences. But actually within that, the similarity is when you look at the data, Embrace data has already been spoken about, and then we've got 5 times more. All of these different datas and reports that come through, the similarity is that Black African women across the board have consistently poor outcomes and experiences when compared to white British women. So centering community voice, service user voice in co-production, in finding solutions and, centering and investment of resources is key to increasing equity, to improve outcomes, excuse me, and include them as equals. So they are the experts of their experiences, and they have a right to person-centered good quality and safe care. So what we did as part of this project, we were very fortunate that as a partnership, we partnered with an organisation we have in Reading called Utilivu. They're a women's group. The word Utilivu, I've asked them when we started working with them, what does it mean? And they said patience. And so what we did, we partnered with them and they were phenomenal. Again, it goes back to sharing resource. They allowed us they invited us actually into the space that they have to work with them and the women that they work with. and we pulled together co-production focus groups. The first focus group we ran was really about going in and asking questions. This is what the data says. Why do you think that might be? What do you think the barriers are? Why do you think Black African women are kind of making their maternity booking appointments later than maybe women that have different ethnic backgrounds? As part of that, also what we did is we co-produced a survey that went online over the summer, just so that we knew that it's much more difficult to be into community spaces with women in the summer months because of childcare difficulties. So the survey sat online over the summer and we promoted it. We then came back and we developed a draft alongside the Trust and Utilivu, a draft poster, so a leaflet. That leaflet, that draft, then went back out into another focus group with more women, and they picked it apart and they told us what was missing and what was there that worked. As part of that process, alongside that, I also met with different community leaders that I consulted with around this particular topic, asking them what they felt the barriers were. So that was Dr. Esther Kurubo Owenga, who she's a Utilivu chair, but she's also a fellow at Reading University of Community Participation Action Research. So her day job is literally learning, teaching people and exploring ways and developing ways of listening to and involving our community in research and action. Reading Refugee Support Group, our councillor at the time, who was Alice Mapofu-Coles, who's now our Mayor of Reading, and lots of other people along the way. And then what we did, we closed the feedback loop. Before I move on, I did want to say, when we talk about focus groups, that any focus group that we run with our service users, they are paid the NHS PVV rate of £20 per hour. And so that's important. We would never expect them to give their time and expertise free. They are paid for their time. And something that we changed as part of our MNVP was that we now pay cash. We ask for a signed receipt so that we can evidence where our money goes. But there's no point in giving families Amazon vouchers, because actually for them, they need that money for day-to-day living, and Amazon vouchers are okay and work for some people, but not everybody. So everyone gets paid for their time. The other thing I wanted to mention in terms, and it links back to the conversation around interpreters today, is we were very fortunate with this piece of work that we, in partnering with Utilivu, is that they provided an interpreter, the wonderful Sharma, who's one of their outreach workers, because as part of our funding, we cannot provide interpreters. That's not to say that that won't be something that we look at, and isn't something that we've looked at, but we were very fortunate around that. And as part of all of this work, and this is just some of the work that happened, is I just did want to credit Dr. Leila Rashamba, who's a consultant gynecologist and obstetrician at the Royal Berks, and she gave of her own time. And everywhere, not everywhere, but most of the places I went, even at weekends and all sorts of times, she came along to really, really engage with the community and really push this piece of work. So I just think it's important to give credit where it's due. Next slide, please. So these are just some of the faces and some of the women and some of the voices that were involved in this piece of work. It is my privilege today to speak to you about this piece of work and the impact that it's had. But it isn't an I, it's a we. You know, from Danny, my co-lead, to our team, the Trust, Utilivu, our partners and the women. The P in the MNVP is partnership, and it's teamwork makes the dream work. So I think it's really important when we speak to these pieces of work that we do, that we credit those that made it happen. We can facilitate things, but actually without the voices, without the women, without these faces here and my team, I wouldn't be here to talk about this. So I think that's really, really important. Next slide, please. So this is the leaflet that we co-produced. And again, it was with the trust. They were very invested. It did take longer as a piece of work than may have been desired. But again, we had to build those relationships. The women, the community leaders, Utilivu, Reading Refugee Support Group, Reading Community Learning Centre, as I said, Dr. Esther Oenga and Dr. Alice Mapofu-Coles. What did we learn? When we spoke to these women, we learned that their maternity information, their education comes significantly more likely to come through friends and family, often who may not be in the UK, and more often than not have no experience of maternity systems in the UK. There were two main themes in terms of barriers, and that was education and access. In terms of education, they were not aware of the necessity to make their booking appointments for the 8 weeks or why. So they weren't aware in many cases of what the risks were and the necessity for the earlier appointment. Interestingly, when I first started this project, I Googled maternity appointments and across the board it said 10 weeks. And so the information out there is not suited to all of the women in our really diverse communities. Access, many women believed that you would go to your GP and they would refer you. We know that that's changed and they weren't aware of that. Some women shared that they had they'd contacted their GP to make an appointment. The appointment wasn't for 3 weeks. By the time they had the appointment and was told they needed to self-refer, it was later than the 8 weeks. And also in terms of where and how to make your maternity booking appointment. So as part of this piece of work, we fed back to the trust that actually when you went onto the website looking for the form to fill in online, it was right at the bottom of the page. And when you're on your mobile, it was literally swiping. So they moved it to the top of the page. That was a really, really easy fix. But as part of developing this poster, we wanted to make it clear it was 8 weeks. We didn't want to frighten people, but at the same time, speak to the necessity of it. We know that data is a privilege for some, and QR codes are great if you have data and if that floats your boat kind of thing. Some people need the confidence that you get when speaking to a human, and a telephone number as part of that really, really helped. And the fact that it's free. So this was the poster that the women designed and agreed alongside the trust, and that we published and printed and that we distribute in our community, across our community. Next slide, please. So it's really important to close the feedback loop. We do lots and lots of pieces of work, and we are trying harder to feed back to community. What do we do with your voices? What's the point in telling us? What's the point in working with us? So in October, we had a community event, and it was the first one we've run, excuse me. And it was a celebration of community voice and co-production. And so we invited our statutory partners such as Healthwatch, our Director of Midwifery, Sarah Bailey, spoke, Cicely Mwaniki, who's the founder of Utilivu. She was a mum in the UK, having travelled from Africa, very isolated, and started Utilivu as a way to try and alleviate some of that isolation and need. Alice Kinjapi-Clifton, Healthwatch, and Carrie, who's here today, our fantastic Women's Health Lead from Bob, who was one of our LMNS partners, who spoke, because it's really important we share our platforms and we work as partnership. We are planning another, this to be an annual event, because again it is really important we close the feedback loop, because otherwise we need to build trust. We need also we are accountable to our community, and so telling them and sharing with them the differences they make. And actually this was about celebration of what works well, because in all of the other spaces we go into, the focus is always health inequalities. So let's talk about and share with them, what are we doing to increase health equality in these spaces? Next slide, please. So this is where we are now. So this shows some data from April 2025 to January 2026. As I said, the Trust, as part of this, changed the position of the booking form. What they've also done is they prioritise, they kind of changed the system by which they triage the maternity booking appointments. So now what they do is when the ethnicity is given at the booking, they prioritise allocation. So as part of that, that doesn't mean that women are kind of come in earlier. So it's how all of this work combines to create these results. So the takeaways are, from the work that we did, surveys weren't, on this occasion, were not effective in gaining feedback. It just didn't work. I'm not saying it's not a useful thing to do, and it doesn't mean it won't work in the future, but it didn't work on this occasion for us. Never assume people know more than what you think they know, and people know less than what you think you know. Community is a verb, not a noun, and that was shared with me by our wonderful Kerry Granger, and that comes from Cormac Russell. Sustainability, because the work is never done. You don't tick this project off and say, oh, well, great, you know, the data's looking significantly better than what it was. We can't do it alone. So our community, when they come along to events or parts of conversations, we share the leaflets with them and the conversations with them, and they're very, very keen to take those out and share it with their neighbours, their families, their friends, and our partners equally. Partnership is everything, and we embed this into all of the conversations we have. Every conversation is an opportunity to talk about the work we've done. Do you know we've done this? Do you know, oh, I've got a leaflet. Would you like that? Have you got someone that you could share that with, even if it's not useful for you? So we do that everywhere we go. That's it, I'm done. I hope I've kind of stayed in time. I get carried away because I love this and I can't stop talking about it. So if anyone's got any questions, please just ask and I'll do my best. And I've got Danny here too, so please just ask.
Thanks so much, Denise. What a fantastic presentation, and I love to hear the passion that you have for this piece of work. I will just move us on the agenda because we are running a bit behind, but please do put your questions and comments in the chat. And Denise and colleagues, are you able to use the chat for a bit of a question and answer session there? Thank you so much. Really fantastic work. And the thing that really stuck with me is that community has the answers. That was really profound as well. So thank you so much. Okay, so we're going to move on swiftly to Simeli Madel, who is going to talk to us about the language discordance, another dimension to maternity care. Over to you.
This follows on really nicely from Mary Claire's talk. So if we just move on to the first slide. I will go past to the next one as well. So already in the introduction, we know why it's important to have good language support for non-English speakers. And just to point out on this slide that as an NHS, not just within maternity, there's a new policy that was launched last May about improving community language translation and interpreting services. So there also is a kind of policy driving to make this overall better for service users. Next slide. So what we did was we interviewed midwives across UH Sussex and asked about the support that was offered to non-English speakers. And then we interviewed 15 childbearing people, service users, so Arabic speakers, Bengali, Polish, Lao, Thai and Turkish, and from an array from first-time mums to multits, and those who'd had their care prior to the pandemic, during lockdown and emerging from the COVID lockdown. And all the data that was collected, that over 55 hours of interview data was collected, and it was analysed through a framework called constructive grounded theory. Essentially, you're picking out codes which are essentially themes from the data that will go in towards producing like a mid-range theory or a diagram of what's happening. Next slide, please. I just wanted to give you a little snapshot of some of the recruitment information that we had. So the top half is Arabic and the bottom half is Bengali. And working with professional translators was so important, just in the way of framing the letters to recruit participants. For instance, in Arabic, letters not really started off with dear so-and-so, and just those little minor things that you don't think about when you're inviting people to come and talk about their perinatal care. Next slide. I feel like this is the most important slide because it's going to give you an example of what service users said. So can we play the Arabic interview? So that was just a little excerpt of service user describing the complexity of the conversation and that the reassurance when things were repeated so that everyone understood. And then the Bengali interview. So this really highlights like the structural problems with existing antenatal care, where there's this 1 hour slot to try and complete all the clinical activities and the discussions around each appointment. And for this instance, the face-to-face interpreter was only booked for an hour. And next slide, please. So what did we find out from conducting this piece of work? Well, actually, from the booking interview, there needs to be a plan in place. There needs to be a language plan, whether we're using interpreters on wheels or whether we're having over the phone interpreters. It's also time to discuss the involvement of kept partners, and that they know that with informed consent, the need for professional interpreters. And then the other layer was that there needs to be this interdisciplinary training. So we're looking at a piece of work where we're going to simulate an emergency labour scenario, but with an interpreter within that dynamic, so that we work more as an MDT team with be a community interpreter or a professional interpreter, and how to make that situation better for service users. Next slide, please. So this is just all the references. I kind of really whizzed through the work that we went into. And then the last slide. And that's any questions, answers.
Thank you so much, Sumeli. Really interesting to hear about the work that's going on through academia as well, through the University of Surrey. And I think there was a comment in the chat a bit further up about, you know, how some of the outcomes tied to dedicated teams and things, and the importance of, I think, some of this research that we're doing to inform the practice that we are seeing in the real world as well. Any questions for Sumeli or any comments? Claudette, do come in. Nice, lovely to see you.
Hi everyone. Hi Sumeli, thank you for that. I just wanted to find out, I know there's the language faculty at University of Surrey. Is there any work linking this to the ambient voice technology that's being explored by NHS England in maternity settings, or not yet?
So is that kind of using
For
kind of
transcribing,
Alexa type technology? That
exactly,
kind of
for
technology.
transcribing clinic appointments, interactions between clinicians and patients?
So they do, the interpreting department do look at that area, but not within healthcare at the
Maternity.
moment.
Okay.
So that is an area that needs to be explored. There is a project going on at the moment looking at AI and the use of Google Translate and those kind of things and large language models within the NHS. But that's kind of looking at it in a cautionary tale and being a bit more, don't just assume that because you have that as your reader on your website that you have provided the accessibility that you need. But yeah, there are bits about what you've brought up would be really interesting to pitch them, because that would be,
yeah, there's some bits on NHS England website if you want to look into it, but happy to connect outside of this if it's something worth exploring.
yeah.
A great question, Claudette. Thank you. And yes, really exciting, some of the work going on with ambient voice technology, and I'm sure that there'll be considerations of translations down the line as well. Any other questions for Sumeli before we move on? Okay, fantastic. So our final presentation is a video presentation. Unfortunately, Lara, or maybe fortunately for her, is on holiday, so unable to make today's, but she was really keen to share the ongoing work that has been going on with maternity hubs in Sussex. So we will play the presentation. Thanks, Sasha. Thanks, Sasha, for sharing the presentation there, and fantastic work going on in Sussex. Thank you to Lara, Sharon, and all the team working there as well. Does anyone have any comments on the presentation? Got a couple of minutes. No. For me, I think it was really, highlighting the importance of all the systems that have done their work in understanding their populations, their kind of accessible information, the system working and sort of thinking outside the box a bit and thinking of alternative care models, so pregnancy circles there as well. And just wanted to give a shout out to, I think Helen's still on the call, Helen Jabinji. They mentioned in the presentation about the jaundice work that the RHO had done and that pioneered in the southeast here with Helen and her team. So shout out to you guys there. Okay, so just wanted to say a big thank you to everyone for their time and engagement throughout this morning's session. It's been so valuable to come together as a region to focus on some of these important issues as we carry on our work. Just wanted to say a special thank you to our speakers for their generosity and expertise. All of your contributions from sharing practical learning and reflecting on those with lived experience and system level change has been really central to the impact of today's session. So I hope that as you leave today, that I encourage you to take one thing you've heard, a challenge, an idea, a commitment back to your teams and ask how it might shape the way that you work. And it's these small, consistent changes across systems that can drive meaningful, lasting improvement. So thanks again for attending. And I think we've got just one more slide. Thank you. If you would please complete our feedback form to make sure that these webinars continue to meet your needs. Yes, Helen, the slides will be shared, and we look forward to welcoming you at our next webinar, which we're hoping will be in early May to celebrate International Day of the Nurse and International Day of the Midwife. So do, if you have a think about presentations that you would like to share and showcase your work, and contact myself and Sian. I'll pop our email addresses in the chat. One final shout out to Sasha, who has been my technical support today. Thanks, Sasha. Let's give you a round of applause. Fantastic. And without any further ado, I will close today's webinar. Thank you so much for attending and enjoy the rest of your day. See you next time.
Yeah, thank you.
Thank you.